Let's move to the next topic, which is decision making for LC2 pelvic ring injury from Dr. Sukhanit Chamchun, Thammasat University. Dr. Sukhanit, please.
Thank you to inviting me to give this talk. So I will talk about decision making on the LC2 injury. So it's a topic that based on the decision making. So I will focus on this. The definition of the LC2. Which one is LC2? Which one is LC1? And how it make us plan for the management. And management, when we think, first we think about, do we need to operate this patient or not? So let's see. And controversial in decision making. So first one, LC2. What do you get in this word is the crescent fracture, right? That is quite classic. But for LC1 is a sacral compression on the back, right? So it seems to be stable in LC1 and unstable in LC2, right? So I will not give a talk on crescent fracture because I already talked 2 years ago at Songkhla. So about the crescent fracture, it's quite the same for management. So you can look back in that lecture. But today I will talk about the controversial point and what is important for make the incision. As I told you, LC1, this from original paper is a compression injury to the sacrum. It looks like it's a not complete fracture on the back. On the posterior cortex is still good, it's still intact. That is quite classic for LC1. But why we have like occult instability as Dr. Pariwat said? Because the definition is not clearly defined. Which one is LC1? Which one is LC2? Okay. So in LC1, LC2 is a crescent fracture. It's quite classic, right? And this one is LC1. What do you think? Who agree with this LC1? Treat conservatively. Nobody. You have some controversial point in your mind, right? Especially on the back, right? On the sacral fracture. This is really LC1 or not, right? And this one, LC2, you agree? Everybody agrees, it's quite classic, right? Crescent fracture on the back. And this one, LC3, opening on the other side, like windswept, right? So it's quite classic. So this, you can clearly define. But the problem is LC2, what is missing? It's a sacral fracture. Sacral fracture didn't mention in LC2, but it's always in there. But sometimes you define as its instability, right? So what we're looking for in the sacral fracture is, do we need to operate it or not, right? So in this literature, they compare open and closed reduction for sacral fracture. But you know why 1 centimeter come from? So many literature cited that 1 centimeter is an indication for surgery, right? So in this paper, this define that the operation will made on the patient with displaced more than 1 centimeter. And it is effect on the outcome, the 1 centimeter. So this study only show that the neurologic injury that can affect the outcome, not the displacement. And another study use also the same, less than 1 centimeter displacement treat non-operatively, and they success it. 99%, only one case that fail and have the late displacement. So if we based on this, most of our case is conservative treatment, right? Okay, but another later literature is not good at this paper. Okay, they have some occult instability, as Dr. Pariwat mentioned. So the predicting that they have so many factors that, like we calculate score in last talk, right? Displacement, comminution, and also the initial displacement. Okay, in this paper they use only 5 millimeter to treat, to looking for the late displacement. Incomplete fracture, less likely to displace. That's straightforward. But complete fracture, significant get a rate displacement, especially in bilateral lamina in the front. Okay, Why it's important to look at the back? Because the fixation on the back is the most important thing in pelvic fracture to get the stability for walking, right? Anterior fixation is only augmentation of the posterior fixation. So that's why we focus on the posterior. So in this literature, you can see incomplete fracture, only 2%. Complete, 50% have leg displacement. And if we combine with a lamine fracture in the front, one lamine, only one side, 33, but 2 times more if you have bilateral lamine in the front. Okay, so the operation is based on the displacement on the posterior, less than 5 millimeter from this literature, okay? And it's important that not only the displacement that we define as the indication for surgery, but also the mobilization of the patient. If they can mobilize within first week, so it can define that it's become stable, right? To mobilize, it's not occult instability. That you have to look at the clinical also, not just look at the displacement, okay? And how can we really measure this displacement? Because initial is static film, right? Sometimes they have a binder, so it's obscure the displacement. And also, the measurement in fluoroscopy, if you test it intraoperative fluoroscopy, can you measure? Do we need to calibrate it to how many millimeter? Okay. And this is already talked. I will focus only the LC injury. So most of the case in LC1 is can treat conservatively, but some is not by this testing. In LC injury, we use this internal rotation and push the pressure on the GT. Okay. And we call 15 image because we have 3-view AP inlet outlet and use this like static internal straight, external straight, and push and pull. This is all the image that we use to test occult instability. But for LC, is focused on the internal rotation. Okay, and they propose that LC1 can be divided in A and B because A is stable, can treat conservatively, but 1B is not. Maybe require the treatment of fixation. And LC1, they recommend to use this 1 centimeter. Less than 1 is stable, no fixation. In the front, the overlapping of the lamine. Okay, and 1 to 2 is anterior only fixation. More than 2 centimeter, both anterior and posterior fixation is recommended. This based on the anterior fixation first. Okay, and LC2, no displacement, no fixation. Any displaced fixation both anterior and posterior. This from this study. And this advantage, we talk about the advantage, right? But this advantage is that required sedation, operating room, surgeon, and amount of the pressure that we push didn't measure, okay? And radiation exposure and cost of this test. So we have the lateral straight film that Dr. Barat already showed. To get this, they compare with the EUA. It's quite the same result, okay, in this study. And operative management on the LC1, actually, as I mentioned, is not totally agree in every doctor. So they make a survey in 111 OTA member and got only 4 cases that agree for operative treatment and only 5 that conservative treatment. But in between, that is the point our decision making, okay? That's what I mentioned. And how much fixation is required? Posterior only, anterior, or both of them? The fixation stability sequential is based on occult instability and testing in that paper. This paper proposed the posterior first fixation and then repeat EUA and look at the front. If there are any instability in the front, so we fix anterior afterward. But if not, only posterior fixation is adequate, okay? So different from the first paper that I mentioned. This, for example, that use this protocol. It look not so much displacement, right? But for the straight wheel, it's increasing, okay, from the static on the left and internal rotation on the right. And they fix posterior first, and then test again in the front. And it displaces in the front, so they fix anterior again, okay? And this is final X-ray. So, in conclusion, how do we treat LC injury? Incomplete fracture, non-operative, right? If fail to mobilize, maybe operative treatment and use the AUA. Complete fracture, fix and make a sequential EUA protocol, as I mentioned, posterior first. And bilateral anterior ring injury, at least one side should be fixed. You can leave only one side of the ring. If you fix everything and you have only one side of fracture, so you can leave it because it's stable enough, okay? And allow the patient to move. And for the literature that put the posterior fixation only in unstable pelvic ring, I will not talk about stable. This is unstable rotational, type B. And they include LC1, 2, and type B. Percutaneous fixation on the posterior only. Revision rate is only 8%. And need additional anterior stabilization is only 8%. So most of the case is successful treat with only posterior fixation in this literature. And they have a secondary displacement less than 80% within 5 millimeter. And in negative study of the stress test, it only can define that it can heal without significant displacement in this literature. So what we get from that, not the protocol for the treatment, but for make sure that it will not displace, okay? Yeah, negative only tell us about that. And this is for case example. Case one is iliac crest fracture, fix of the screw fixation, and they can mobilize without any problem. Case two, only posterior fixation. Because of the concomitant injury of the both lower limb, they ambulate with wheelchair. So only posterior fixation is chosen. And third case is classic crescent fracture, fixed on the posterior with a plate and screw, and anterior with a X-fix because of the urologic injury problem. Case 4, okay. So this is for just case example, okay. For the fixation, we have screw plate, okay. And take-home message is that the dynamic stress-based make a decision-making more than the static. EUA guide treatment, and more aggressive surgical treatment is can reduce lead displacement. Fixation is stable, increase risk of the complication. So more study is needed for determine the effect of our fixation and displacement on the function of the patient. Thank you.
Okay, thank you so much for the good presentation.